And
Great. Hello, good afternoon, everyone. My name is Bal. I'm one of the medical SHOs on DSHAM ward. I am involved in this Friday weekend handover sheet. Um, so I'm here to present some data that we have produced after the introduction of the Friday ward run. I'd like to first say thank you to everyone that was involved in utilizing this Friday ward run handover sheet, especially all the medical wards in the Conquest Hospital and a few selected in Eastbourne. And again, thank you for participating in the project. And moving on, before we discuss the data, there's a few changes based on user feedback. We've asked a few, especially junior doctors who utilizes this Friday weekend ward run sheet, if there was any changes there was needed. The first is the Friday acronym checklist. For some junior doctors, they reported it as a bit confusing. So we added a bit of descriptions to help them solve this problem. And also there's a little box under the diagnosis and problem list, just a simple reminder to complete that prior to the weekend handover. We are updating the sheet regularly based on user feedback, so keep that updated. And just a reminder of our aim and objective prior to starting this Friday ward run handover sheet. It was just to enable the better communication between the week team and the weekend team, to enable safer handing over and to improve the doctor's well-being, and in perspective to their time management, a basic reminder to set escalation plan, which I've seen vast improvement, and this has helped us manage the surge better. Although this should be a standard care in a normal day-to-day practice, it's been implemented quite well. And finally, just to ensure uniformity, that all wards are utilizing the same handover, which I have seen everyone using. And me personally, it has helped me a lot, especially on the weekend on call, just knowing what sheet to look out for, where specific diagnosis or the current management plan is set. So going on to the data collection, so we have acquired data on various wards at random weekends, prior to the weekend, sorry, uh, before and after the implementation of the weekend handover. We've collected these various data from various wards on Conquest Ward and a few again over at Eastbourne, looking out for the Friday checklist as stated in one of the boxes. We made sure that they are being completed and being followed through. And with these results we've collected, I've noticed that there have been big changes that you guys have made. So based on the data collection, you guys have actually made a change with the ceiling of care, especially prior to the introduction of the weekend handover sheet. 44% of patients had a ceiling of care, documented it in their documents, but after the implementation of the weekend handover, there has been an increase up to 81% of patients have a documented ceiling of care plan. This is an increase of 33%. The same can be said when we were assessing if a patient has a DNAR form, if applicable for the patient. Prior to the weekend handover sheet, 74 patients, although very good standards to set, we have managed to top that, and now it's increased to 96% of patients have a DNAR form. This is an increase of 22% of patients. Moving on, what troubles us most, especially for myself, is having to complete discharge summaries for patients that I am very unfamiliar with, and this is my biggest concern. And prior to the Friday ward down sheet, 60%, or they're very great, have completed TTOs, including clinical summaries. This has increased to 100%. Although, again, this has been the data has been collected at random intervals, a random week of choosing. We may have hit the jackpot on this one, so there is an improvement on this. There's an increase in 40%. of the TTO is being done for patients that may require to be discharged over the weekend. But as promising and as important as the data results show, we as a team value what the doctors who utilize the Friday ward round sheet have to say. So we sent out a survey to randomize selection of doctors again after the implementation of the Friday weekend sheet. This comprised of 15 junior doctors, which include 4 registrars, and we included 5 consultants in this survey as well. We've asked you guys how frequently do you get asked jobs that could have been done, get asked to do jobs that could have been done by the parent team or the weekday team. And prior to the Friday weekend handover sheet, 70%, if you guys remember, 70% of the junior doctors said that the occurrence is very often or often. This has dramatically increased in frequency, as in drastically improved, sorry. Sorry, I'm just going to move it. Yes, the frequency of junior doctors getting asked to do jobs that could have been done by the parent team has decreased by nearly 43%. So the frequency of often and very often accumulates to 27% now, as opposed to the 70% prior to the weekend sheet. We also asked the junior doctors of ease of understanding of the clinical summary, how well they look through the notes and understand it. And prior to the implementation of the Friday ward round sheet, 70% of you said it was difficult or very difficult. This has dramatically improved, and 100% of junior doctors are saying it's now easier to understand the clinical summary with the handover sheet. So again, noted, only if the sheet is filled out properly. It's very user dependent, and if it is filled out properly, then again, people are saying it's easy, but if not, then we're back to square one. Asking the registrars their viewpoint and how easy it is to understand their clinical summary and how easy it is to decipher an escalation plan with the weekend handover sheet. Before the weekend handover sheet, 60% said it was difficult, 40% said it was easy. Now this has improved to 100% saying it's easy or very easy. This is a big improvement for us, especially during MEC calls when it's vital and time crucial. Time management with the Friday ward round sheets, both the registrar and the SHO said, the majority of the SHOs and F1s said it was better for their time management, although 27% were unsure, or 27% of the F1 and SHO were unsure of how it affected, but overall there's a better time management with the Friday weekend handover sheet. We included the consultants into the survey, asking the consultants whether or not it was user friendly, all of which said it was, and particularly the safety around patients, if they had any concerns. No one had any concerns, which is a big plus for us as well. And just generally open feedbacks on what we need to improve in or what's going on. Some have said it helps with the weekend team, particularly with the escalation plan. Some have said encourage everyone to use the sheet fully and fill out all sections. Again, this is quite vital. If it's not filled out properly, then it's quite useless, the sheet. But if it is filled out properly, it can make a big difference. One person said, keep up the good work as we need this. And I do agree. So overall, keep up the great work, and thank you very much for your cooperation with this project. I'm going to hand you back over to Saad.
Right. So just a few things clarifying. So I think so the sheet we are talking about is the Friday ward round sheet, which we all are using. So of course we know like it was introduced with the idea that we have a clearer summary for the weekend team who do not know the patient or probably do not know the patient if they were asked to see the patient in an emergency. Similarly, the escalation plans and DNR section, along with this checklist, that is the job of like jobs that we are asked to attend in relation to over the weekend most frequently. So overall, the result seems promising. In all fairness, it is not surprising at all. We had taken this idea from a couple of other trusts where it was already been implemented and the results were more or less the same. So it is not a surprise that we have managed to achieve this. A few things which I would like to mention though is that at the end of the day, it is a user dependent format. That sheet is nothing more than a piece of paper if it is not used properly. If people start to ignore the sections which have been tried to be highlighted, it would not achieve anything at the end of the day. So the way of getting the maximum output out of the idea, which initially started in Wales and has been taken up by many trusts now, is to pay attention to the reminders that that sheet is designed to give to the user, and then maybe possibly act on them and try to make the lives of your colleagues over the weekend a bit easier and make the care of your the patients a bit safer. Yeah, it's as simple as you scratch my back, I scratch yours. Right, one day you would thank your colleagues for doing a good job before the weekend started, because you did a good job today for them. Last point, which I think I must make, is in relation to the TTOs. I do think that 100% is more of, I think we just got lucky on the weekend. We decided to collect the data because as good as it looks, 100% of the people had their TTOs and the e-discharges done if they were thought to be for potential discharge over the weekend. I do think I personally have never come across a percentage of 100%. So possibly it was more of that was a particularly good weekend. Everyone was in a good mood on a Friday and just ended up getting everything sorted. So, but the data would be collected probably on monthly basis, but we will keep an eye on it. We'll keep on collecting the data. Yeah, so if there are any questions, I'm happy to take them now in relation to the Friday ward round sheets. Yes, Dr. Fong, go for it.
Well, first thing I just wanted to say to you and Bao and the rest of your team, well done. I think that's really, you guys deserve a pat on the back for what is a very simple but important piece of work. I think it's nice to see that it's something that has made some big changes. I would say from a consultant perspective, because a lot of you don't see the complaints we get for the patients you might be caring for the weekend. One of the biggest issues later is the lack of documentation. Of course, a lot of things have happened, but if you don't document it from a legal perspective, it doesn't exist. So even having this kind of wards sheet, in terms of not only does it improve your communication, gives you better outcomes and have better discharges and reduces the workload on the ward team, but it also helps from a legal perspective as well, actually. And I know that can sound a bit boring, but it's very important. So well done. I think that's a really great project you guys have come up with. So great stuff.
Thank you very much. Just something that just suddenly came to my mind is that now, in order to make it now, because we have updated the sheet the way it suits us as a trust based on the feedback, and just to make it a bit more easier for everyone to use, the plan is to actually upload it on our intranet. I will send a message out to everyone, let you know when it has happened, so it would make it easier that every Friday morning whosoever comes at 8:30 just prints out the required number of sheets for their particular ward, rather than have to photocopy it or for me to actually drop it to every ward. So that is something that that is coming. Hopefully that will also make the life a bit more easier, and I will let you know as soon as it happens. Moving on, I do have another project coming, which is again as simple as Friday ward round sheets, maybe even simpler. Let me quickly bring that document up and share with you. Where is it? Downloads. Now, can I confirm? So, are we seeing the sick and the quick currently, or are we still seeing the
Sick
sick and
quick.
the sick and the quick? Brilliant. Now, so I am sure almost all of us are aware of the safer bundle that was introduced by NHS Improvement quite some years ago, actually. And in all fairness, one way or the other, in some form, it is being followed trust-wide. Safer bundle is essentially targeted at that without compromising on patient safety, which of course is our foremost priority. We look try to proactively look at the discharge process which the patient would be requiring. Similarly, NHS Improvement has set out certain targets for us, which we have to comply with in relation to discharge processes and transfer between different specialities of the patients, for example, from acute specialty to specific specialty. So talking about medical beds, I think the trust would really hope to see potentially around 6 discharges on each side from acute wards to their relevant specialities on like medical wards before 10 o'clock. Now, that's a target that we have set the bar high for ourselves, so that we try and strive in order to get in order to achieve so that people are in the required field where they should be, in a specialty where they will be better cared for. Similarly, regarding discharges, we have some target of, I think, 33% of discharges to be achieved by midday, 12 o'clock. This, I think, is our NHS Improvement target, which has to be met, like, one way or the other, or you strive in order to meet it. In order to make our discharge process a bit more smooth, we after discussion among ourselves, and then from experiences from different other trusts, have come up with the idea of restructuring our ward round slightly from the way it is being done currently in most of our medical wards. That brings me to what we have tried to give it a very catching name of Sick and the Quick, or Sick and Quick. This project actually targets that early on in the morning, when the night staff of the night nursing staff is handing over to the day nursing staff, the handover, which has now moved on to a nerve center, so it's all electronic, they are able to highlight a few potential candidates. Number one, who have been unwell overnight and require a earlier review, meaning thereby are sick people that should be seen before we start seeing the rest of the people on the ward. And then the few patients who are potential discharge on the day. So if I have, let's say, bed A5 and B6 who are potentially going home today, according to the nursing staff, they would put that people on that list, which will get highlighted to us, and we can see our unwell people to begin with, and then our potential discharges, which on a particular ward, based on previous experiences, I wouldn't say there'll be more than 2 or 3 or 4 at best. And then the rest of the people can be seen like in whichever order a particular team would like to see them. This is actually the standard way of ward round in a number of other places where I've worked, and what is being recommended in order to achieve a better bed state for us, so that the movement from acute wards like AAU and A&E is not crowded because there are no beds available somewhere else in a specialty where a patient needs to be moved. In order to achieve this, we have come up with the idea that on the nursing handover on Nurse Center, they have a tab so, like talking about the AIMS, they have a tab that says priority review, as highlighted here. If a nurse decides that this gentleman needs to be on the priority review, she clicks on the priority review during their handover, right, and that gives them an option of, is the patient for priority review? Yes, because they are unwell, or yes, because they are a potential discharge for the day. They may like to put some details here. For example, if that patient is unwell, the patient had a met call overnight, like the day team might like to review this patient straight away, right? And this will auto-populate a list by the name of Sick and Quick on Nerve Center, which I'll show you in a second. Right, once this is done, similarly, a couple of patients might come under yes, because they are potential discharges for the day. It will appear on nursing handover like this. Having said that, that's not what we are looking at. What we are looking at is that when I come at 8:30, I go to my ward, I log into Nerve Center, and I search here for Sick and Quick list. Now, I must mention here that it is not available at this moment. So if you'll try to do it while we are talking or later on in the week, you would not find this list, because currently it is being frozen for some technical reasons. It will come into effect from 15th of March, so next Monday. Right, this is how it would appear. Once you have searched it and clicked on it, it will appear on your recent list, so it would be fairly easy to find. When you go into Sick and the Quick, it would show all the patients on the medical wards that have been put on Sick and the Quick list by the night staff while handing over to the day nursing staff, based on either they were unwell or they are a potential discharge today. Now, I am only interested in bed. Let's say if that's where I'm doing my ward round. So if I click on bed, it will categorize them on the basis of their ward, and then I'll be able to see that I have one patient, let's say here, who is on Sick and the Quick list. So I can see that patient first, or let's say if I have all three of these people under me on bed ward, I can see the sick people one first. I can see the potential discharges, and if they really are fit to go home, then they can be the decision can be made sooner rather than later. And if we are having a good day and we have somebody who can break off the ward round and do the TTO and the discharge summary straight away, that patient will be out of the hospital before midday, let's say before lunch, definitely, which I'm sure he will appreciate more than what we will. Right, and so trying to just restructure the way our ward rounds are conducted on medical wards, which I am sure most of us do it in one the like like we see our sick people first. Is just a way of formalizing it and including our potential discharges for the day into that cohort of the people that are seen before the rest of the ward is seen. This project is planned to start on DSHAM, Newington, DSHAM, Wellington, and possibly Baird from 15th of March. And from the next week, Monday, it would go live for all of the medical wards. The delay we are unable to do it at a single time is because it needs, we need to speak to like almost all of the medical workforce and then the nursing staff, so that they are aware of what it is, how it would work. So I'll be popping my head in almost literally in every ward while the project is being initiated, to provide any sort of technical or any other questions that may be there for me to answer. And we hope that just this tiny intervention would bring significant results in terms of our patient safety, potential discharges, and then bed state to play around with for throughout the hospital, and preventing stasis in AAU and ANE particularly. If there are any questions, I'm all ears. Provided I haven't forced everyone to go to sleep. Yes, Dr. Fong.
That's a very interesting project, Saad. And it's nice that you're using the nerve center, because obviously I think that's where we're headed in terms of the future, in terms of hopefully electronic recording of notes and everything will be on there in the future as well. I mean, we can see some of that being done in A&E already. Just so I'm clear, is this something you're planning that we access every day of the week, or is it mainly weekends that this is most useful?
Well, essentially, I mean, whosoever is doing the ward round every day. Yeah, so that's the idea behind it. So it doesn't, I mean, the wards where, let's say, consultants do twice weekly round, right? So consultants will be doing it on those 2 days, but whosoever is doing the round, the F1 SHO, registrar, or the consultant, like if we go in that order, hopefully, like we'll be able to uh, potentially discharge our dischargeable patients on the day sooner rather than later.
Okay.
Yeah, so in
I
short,
think it's
like
nice.
every day.
It's as with all things, I think it will evolve over time, but I think the concept is really good, and we just got to see how it tries out on the ward, isn't it? But
Indeed.
it sounds interesting, and I hope it actually works out quite well, because it has a potential to hopefully make things a bit more efficient, a bit quicker. And like you said, it's about seeing the sickest patients properly, knowing that they're there, and getting people home if they don't need to be in hospital.
Indeed. Indeed.
I'll wait and see if there's anyone else other than me doing all the talking.
Clark,
Go ahead.
as a message, or is it? Yes, Dr. Clark.
Hi, Saad. Very good project. One question is, obviously nurses going to be the leading forces for that, and they have to be kind of properly trained and to be aware of this. Some of the words are excellent with that. I mean, AU is brilliant. And I mean, I find sometimes on weekends when you're walking around asking who's ready for discharge, you think there's some kind of reluctance in that. So we just need to change morale and general kind of idea for the nurses to escalate these people and to feel that they're empowered to do that. That is priority. It's not only doctors telling them patient is medically fit. They actually need to could be kind of 50, kind of 99% to be sure they are fit, just to get doctors to come and sign the discharge letter. So that has to be trained. I mean, thank you for grand round and escalating that. Obviously, we will use it, but somehow it has to be kind of get to their to nurses, even if it's, I don't know, locum or any seniority, that they know patients better, they spent all night with them, they understand who is medically fit. And I don't know, maybe doctors before the day they're leaving, they would highlight potential people for discharge for nurses overnight review. I don't know. So if you know that somebody will go home and a board round, you maybe just highlight some people potentially can go home tomorrow. So for nurses, it would be easier to put them on the list, discharge.
I fully agree with that, Victoria. It's a kind of an MDT kind of system, isn't it? And we totally sometimes forget it's the nurses that are such a big component of this. So I think your advice, Saad, is absolutely right. We've got to get the nurses on board. They will be an integral part. It's not just the doctors identifying them, it's the nurses sorting out the rest of it as well, isn't it?
Indeed, yeah. I mean, the number of the people who are involved as stakeholders in the project is like it's many people, 2 cohorts major, doctors and nurses, and yeah, engagement is the biggest part of the project. So yeah, no, thank you very much. I have been, like, in touch with many matrons and the nurses on different wards, and the reason we are unable to start it at a single time is primarily that haven't had the chance to engage with the rest, so they do not really know what the process is or what is expected of them. So I'll definitely, and then similarly on respective wards, anybody who is aware of the idea, the project, what we are trying to achieve. I mean, it's an ongoing process. So it's an ongoing educational element to it on day-to-day basis, to our junior doctors, to ourselves, and to the nursing staff regarding what we are expecting and how they shouldn't be reluctant or feeling empowered in suggesting if somebody, number one, they are concerned about for this safety one way or the other, some overnight event, or number two, if they think the patient is a potential candidate for home.
Saad, if you don't have anything else to present, I might showed the group something quite interesting that kind of follows on with your theme today about having efficient and quick discharges, which is the new weekend discharge tool. But I didn't want to present until you.
Oh, no, not at all. I am done. Thank you very much. Really appreciate all the attention and the feedback.
I think this is a very interesting grand round. It might not be about a case presentation, but it shows you about the different ideas that are really useful. And the last one I want you to guys see, which is really important, because you may have been seeing this on the weekend, is over the last few weekends, we've been trialing a new system to help discharge the patients that are safe and suitable to discharge. And it's a new NHS England improvement discharge support tool. What we've been doing is that over the weekend on the Saturday and the Sunday, we asked the ward doctors to look onto each ward that they're on. So for example, say doctor number 1 is covering Wellington and Desham ward. They would go onto the ward and look onto the nerve center and use this algorithm to help identify patients that would be safe to discharge. The system is actually very quick. It's probably only a few minutes. What you do is you look up on the nerve center, because the nerve center has a list of all your patients and their mu scores, and you can actually stratify the list so that anyone that has a mu score of less than 3 is identified. After that, you just go through this simple algorithm where is the mu score in one parameter or more, say they're tachycardic, and if the answer is yes, they probably can't be discharged. Or they're on oxygen, yes, they can't be discharged. What's the diagnosis? Are they too high risk to discharge, like a stroke or MI? Yes, they can't be discharged. Would we have admitted them from MAU as they are today? And if the answer is no, they stand a good chance that they can be discharged. And what you can then do is identify this and flag it to the registrar or the consultant on the wards. And essentially what you've done is, from having a ward that might have no discharges that you know of, you identify the right people. So this is something that's been happening already for the last few weekends, but it's more for those of you who are dialing in today that do weekend work and ward work. This is something we'll be getting junior doctors to do more often, as what we're noticing is that it really improves getting the right people back home rather than keeping lots of people in hospital when they don't need to, especially during these COVID times. So the doctors that are doing this will I'll be in touch with, and what happens is you might complete a tool just to say how many people are on the ward, and it actually only takes about 10 minutes in the morning. But it's a way of things to come. I think that we are trying to get more people discharged in the right timing. So hopefully it's just giving you an idea of another thing that's happening to help with discharges. I think that's all I'll say about that. Sorry guys, I'm not sure that the screen actually shared with that one. So is that, yeah, so that's the same thing. Anyway, that's it from me. So it was really just a quick bonus discussion for you guys, really. Any questions? Happy to take them, but if not, we'll probably leave it at that for Grand Round. I'm very grateful to Saad for presenting all that data. All right.